in progress.
Mm-hmm.
Okay, virtual folks, can you give me a hello if you can hear me and see our slides? Perfect, thank you so much. Do you want the chat box up or closed until the end?
Close.
Okay. Okay, so virtual attendees, our speaker will get your questions at the end, but go ahead and pop them in as they occur to you. That's totally fine. And then you'll be advancing either here or over here. Either one should work for you.
Okay.
All right, we're going to go ahead and get started with our next speaker. This is Travis Bruns. Most of you probably know him already. He just spoke. Did you have, how many sessions did you have at the MBMA?
4.
Okay.
Yeah.
Wow.
Yeah.
Way to
That's fun.
dominate. Travis is a veterinary technician specialist in anesthesia and analgesia. And I know he has a lot of great information, so I'm going to go ahead and turn it over.
Hello, everybody. It's a pleasure to be here today. So the title of this presentation is Heart Rate of the Anesthetized Patient. The fancy part is the chronotropic effects of autonomic tone and anesthetic drugs. Basically, the whole reason I wanted to talk about this, the whole reason I made a presentation about this is because when I started doing anesthesia as a young tech or assistant, basically if the heart rate went up, I was told to turn the gas up. The heart rate went down, I was told to turn the gas down. And it made sense at the time. I didn't think too much about it. But since then, I've learned a lot more and realized that heart rate is not necessarily an indicator of depth under anesthesia. There are a whole lot of things that contribute to heart rate and contribute to either raising it or lowering it. So if we're going to talk about that, let's start by talking about how the healthy heart paces itself. Most of the heart is muscle, but we have some specific cells that are pacemaker cells. They're at the SA node on the right atrium. They're at the AV node, and they're at the in the His-Purkinje system through the ventricles. So there's a septum between the atria and the ventricles that doesn't allow electricity to go through. The job of the AV node is to allow that electricity to go through. And all these cells that I've highlighted here are capable of pacing the heart. The SA node has the highest rate of pacings. The SA node is the pacemaker. What happens when the SA node goes off is there's something called overdrive suppression, which keeps all those other pacemaker cells from pacing the heart. If the SA node fails, then any of those other cells can take over. But under normal circumstances, everything's going to start with the SA node, going to go through the AV node, and down the His-Purkinje system. So normal heart rates, in dogs, it's going to be about 50 to 120 beats per minute. Cats, 120 to 220, with an average of 160 for cats. And we've all seen dogs and cats with heart rates outside of this. That doesn't mean that they're having an arrhythmia or there's a problem. It means that something in them is driving the heart rate to either be really low or really high. So here's a question for everybody. What is the lowest canine heart rate that you are comfortable with personally during anesthesia? Seeing some good answers. All right, we're starting to settle into it's complicated. Some people are cutting off at 40 beats per minute, a few at 60. So the real answer is it is complicated. A healthy heart in a dog, if you have a hunting dog, a working dog, it might beat at 40 beats per minute and be perfectly adequate at creating cardiac output, maintaining blood pressure. An unhealthy heart isn't going to be able to manage that. So if you have a dog with heart disease and their heart rate gets that low, their blood pressure is generally going to drop. And that's going to be your tip off that you need to raise the heart rate. However, if you have a super athletic dog and it's under anesthesia, its blood pressure is perfect, and its heart rate is 38, 40, you don't necessarily need to do anything about that. You need to look at the whole picture. Most dogs at home, we've got a lot of Holter monitor studies now that show that dogs at home have really, really low heart rates for at least an hour every night while they're asleep. It's completely normal. They do this in their normal life. So if it happens under anesthesia, which is a lot like being asleep, it's not necessarily a bad thing as long as the heart is healthy enough to handle it. We have a little dachshund here because if you ever do any neuroanesthesia, you'll find dachshunds love to have super low heart rates. So the biggest driver of heart rate, the biggest determinant of heart rate in mammals is autonomic tone. Autonomic tone is that thing we learned about usually somewhere in high school, the difference between fight or flight and rest or digest. So sympathetic tone is fight or flight. Parasympathetic tone is rest and digest. And it's not a binary. It's not one or the other. It's not we have sympathetic tone, so that's going to make our heart rate go up, or we have parasympathetic tone, so that's going to make our heart rate go down. It's more of a balance. So if the sympathetic tone is stronger, the heart rate's going to go up. If the parasympathetic tone is stronger, the heart rate's going to go down. They both exist all the time, and they're both going up and down, and it's the balance that determines whether the heart rate is high or low. So let's talk about sympathetic stimulation first. Sympathetic stimulation is a result of your adrenergic receptors being stimulated. Things like stress, fear, excitement, pain. If you become hypoxemic, it will also trigger the sympathetic stimulation. So basically, if something's chasing something or being chased, their sympathetic stimulation is going to be really high. And no matter what their parasympathetic tone is at the time, the sympathetic stimulation is going to take over and their heart rate's going to go up. So that's an easy one to understand. The results of sympathetic stimulation include several things. It increases the sinus node depolarization rate, which is a fancy way of saying it makes the heart go faster. It also increases the conduction speed through the AV node, and it creates a shorter duration of action potential in the working myocytes, or the cells of the heart. So it not only increases the heart rate, it increases sort of every part of the heart activity so that the heart beats faster, it conducts faster, and can put more blood out in a shorter period of time. Another question. What do you know about vagal tone? And as a side note, when I first was told something had vagal tone as a young tech, I just nodded my head and said, vagal tone. I know what that is. So most of us have heard of it, but we don't have a great concept of it, a great understanding of it. Vagal tone is just parasympathetic tone. So about 75 to 80% of all parasympathetic stimulation occurs through the vagal nerve, and that's why they become sort of synonymous. If you want to be specific, you'll say parasympathetic tone, but if you say vagal tone, it's understood to be the same thing. So the vagal nerve innervates most of the central part of the body and the head and neck. So things that have parasympathetic innervation are things like heart, lungs, esophagus, stomach, basically all the digestive tract, kidneys, ureters. You have parasympathetic innervation at the eyes and submandibular area. So everything basically at the trunk of the body and the head and neck, the extremities have little or no parasympathetic innervation. Nothing you do to a hand or a foot is going to cause parasympathetic innervation or stimulation. So bradycardia is often a physiological response to an increase in parasympathetic tone in conjunction with the withdrawal of sympathetic tone. So when you eat a big meal, it's going to increase parasympathetic tone. If you're not stimulated, if you don't go for a run or out on a date afterwards, if you lie down on the couch, your sympathetic tone is going to go down. That parasympathetic tone is going to take over, and your heart rate is generally going to go down. You're in the rest or digest mode. So when an animal is sleeping, after eating, not during eating, after eating, when it's sedated or under anesthesia, you've got a lack of sympathetic tone, and potentially your parasympathetic tone is going to take over if it's high enough. Hypervagatonia is a fancy way of saying an animal has chronically elevated parasympathetic tone. Common reasons for that are your breeds. Your brachycephalic breeds have hypervagatonia as a general rule. Their conformation of their face and the parasympathetic innervation of the face, as well as the effort they have to exert in order to create negative pressure, high enough negative pressure in their chest to inhale, creates a constant stimulation of their parasympathetic tone. That doesn't mean their heart rate is always low, because if they're chasing or being chased, the sympathetic tone is going to take over and their heart rate's going to get high. But as soon as you knock out a brachycephalic breed, their heart rate is going to tend to get low quickly. As a general rule, if you're going to anesthetize a bulldog, be ready for a low heart rate. Is the low heart rate a problem? Well, it depends if the heart's in good shape or not. If the heart rate gets low and their blood pressure is fine, not a problem. If it's an older bulldog with heart disease and their heart rate gets really low when you knock them out, that could be a problem. Gastrointestinal disease can also cause hypervagatonia. I've seen this multiple times in cats with intestinal tumors. Intestinal tumors causing constant parasympathetic stimulation. As soon as you knock them out for surgery to take that tumor out, that cat's heart rate goes down to about 80, and everyone panics. They think it's a bad reaction to drugs, but all that's happened is they have high parasympathetic tone. It's driving the heart rate down. So you need to just increase the heart rate with anticholinergics. Anticholinergics, atropine, and glycopyrrolate, we're going to talk about later. Urethral obstructions can cause hypervagatonia. Respiratory disease, so if you have something with chronic obstructive pulmonary disease or upper airway obstructions, those can all cause hypervagatonia. So if you sedate or anesthetize any of those animals, you can expect their heart rate to go down. Intracranial lesions can also cause it. So some animals with brain tumors. We're going to talk about some of the sort of vagal responses now. A vasovagal response is an acute parasympathetic stimulation resulting in bradycardia, hypotension, sometimes short-term or temporary sinus arrest, and syncope. So if you've ever seen an animal that passes out after it vomits or passes out if it gets really excited, falls to the floor, that tends to be a vasovagal response. If you go on YouTube and look for vasovagal response in weightlifters, you will find that sometimes people who hold their breath and lift a large weight, when they put it down, they fall over. It's because they increase the chest pressure, increase the parasympathetic tone. They're fine while they're lifting the weight and they've got all that sympathetic stimulation. As soon as they put it down and they rest, you'll see this big guy just fall on his butt. So extreme excitement can cause it, exercise can cause it, coughing can cause it. Closed pop-off valve. The first sign that you're going to have that an animal's in real trouble if you left the pop-off valve closed is our heart rate's going to go down dramatically because the pressure is going to build up in the chest. It's going to reduce preload to the heart, but it's also going to increase parasympathetic tone. That heart rate's going to get lower and lower, and that's when you know you're in trouble. I personally had a cat that would have a syncopal episode every time it vomited its entire life, never changed. If it had a hairball, it'd fall over. The oculocardiac reflex is something we've probably all been warned about, right? If you're doing an enucleation, you have to worry about a low heart rate. Digital compression of the eyeball or application of traction to the extraocular muscles can trigger this reflex. There's a lot of parasympathetic stimulation. So when you're doing an eye procedure, particularly an enucleation, be ready for low heart rates. Depending on the health status of the animal, you want to possibly give them glyco or atropine before you start, or have it on hand to give it if the heart rate gets really low. Because if their heart isn't healthy enough to tolerate a low heart rate, that could be a real problem. there's also something called the vagal maneuver. We'll see that our cardiologists do this in practice downstairs every once in a while. If you have a animal that's got some sort of intractable tachycardia, they'll check and see whether it's mediated by autonomic nerves by basically pushing on their eyeballs. They push on the eyeballs, the heart rate goes down. You can do the same thing by massaging the neck of a dog. If the heart rate's really high under anesthesia, you've done everything, you can't figure out what's wrong, you can massage the neck, it'll increase parasympathetic tone. And if that heart rate is mediated by autonomic tone, it'll lower the heart rate. There's something called the basal gyrich reflex. This is something you're not going to see often. You most commonly see it when an animal is about to die. It's caused by vigorous contraction of underfilled ventricles. So basically, empty heart, beating really hard, it's going to trigger this parasympathetic reflex and slow down the heart rate. So where you're going to see this is in a lot of your near death, your shocking animals, something that just bled out a ton. They'll be working really hard to get cardiac output. And when they're circling the drain and the heart is not filling at all, and their heart is beating really hard and it's empty, this reflex is going to trigger and you'll see the heart rate get really low. And that's usually a precursor to cardiac arrest. It's not something you want to see. Now, sudden changes in heart rate are not a result of autonomic tone. Sudden changes in heart rate are generally a conduction abnormality. So autonomic tone may change the heart rate really quickly. It can make the heart rate go faster, make the heart rate go slower, but you'll see it happen over a few beats. This particular ECG that I have here is an animal that was going into re-entry tachycardia back and forth during a dental. Its heart rate would be about 60, then its heart rate would be 160, and it just switched like somebody was flipping a switch. That is not the drugs. That is not autonomic tone. That's a conduction abnormality. So if you see this under anesthesia, this is something you need to bring to the doctor's attention. If it's happening as you're prepping the animal for surgery, maybe this animal needs to be woken up and see a cardiologist. It's a very rare thing. You're not going to see it often. And if you look down and look back and the heart rate's different, it's hard to know whether it was sudden or instantaneous. But if you catch it, a lot of these animals will switch back and forth. And that's an animal that should probably visit a cardiologist. Part of autonomic tone regulation is the baroreceptors of the body. Baroreceptors are essentially stretch receptors. There are arterial baroreceptors. They're at the aortic arch and the carotid sinuses. So basically on the outgoing side of the heart, there are these baroreceptors on the vasculature that sense when the vessel, the aorta, is being stretched. Now, why would the aorta be stretched? It would be stretched if the heart is creating, or if the blood pressure is increasing. So if the blood pressure increases, these stretch receptors get triggered. They send two different things. They send parasympathetic tone to the heart to decrease the heart rate, to say, heart rate's getting a little high, let's slow down the heart. And they send sympathetic stimulation to the vasculature, which causes vasodilation. So basically, they're slowing down the heart, opening up the vasculature, to try to regulate blood pressure. These stretch receptors are probably your primary blood pressure regulators of the body. They're the thermostat of the blood pressure. If the blood pressure decreases, now the blood pressure is too low and those stretch receptors aren't getting triggered at all, parasympathetic stimulation to the heart is reduced, allowing it to get faster. And sympathetic stimulation to the vasculature is diminished, so that vasodilation goes away. So now the heart rate's getting faster, the vasculature is getting tighter, it's bringing the heart rate and the blood pressure back up. So that's a continuous balance, right? It's not an either or, it's a beat to beat sort of regulation in how the blood pressure is maintained. So that can be overridden again. Like everything I'm talking about today, it can be overridden by something else being stronger. If you see an animal come in that's really excited or in pain, it may have really high blood pressure. So the arterial baroreceptors are trying to bring the blood pressure down, but you've got sympathetic tone from the excitement or the pain that's overriding that, and it's creating a hypertensive situation. Once you eliminate whatever's going on, give them some pain relief or get them calmed down, then these baroreceptors will be able to influence the heart rate more directly, bring the heart rate and the blood pressure back down to normal. There are also venoatrial baroreceptors. These are stretch receptors on the incoming side of the heart. They're located on the vena cava and the pulmonary veins and at the opening of the atrial chambers. So when those are stimulated, they send sympathetic stimulation to the SA node. So they increase the heart rate. You can think of this as basically when they get stretched, they know that the incoming or the right side or the atrial side of the heart is full, and they're saying, we're full now, let's go ahead and beat. So when you see, well, here's a good example. Sinus arrhythmias have a lot to do with autonomic tone. When you first start teching and you take the heart rate of a, Labrador that's relaxed and it's really irregular, you freak out. Somebody in the room says, oh, that's just a sinus arrhythmia. And you nod your head and say, okay, it's a sinus arrhythmia. And you walk away. A more complete term or a more complete way to describe it is a respiratory sinus arrhythmia because it's a sinus rhythm, normal ECG trace, and it's being influenced by respiration. If you look at this trace I have here, the top line is the end-tidal CO2. The bottom line is the ECG on this animal. So every time the animal inhales, the CO2 goes down. Every time the animal exhales, the CO2 goes up. If you compare that, line it up with the ECG, you'll see that every time the animal inhales, the heart rate goes up. Every time they exhale, the heart rate goes down. You'll find this to be true of any of your patients with sinus arrhythmias. It's going to speed up when they breathe in. It's going to slow down when they breathe out. So what's happening is when they inhale, the act of inhaling increases sympathetic tone a little bit. It's going to speed up the heart. It also increases cardiac preload because the animal creates negative pressure in its chest. When it creates negative pressure in its chest, that pulls more blood up to the heart. More blood up to the heart increases the load going into the atria. That's going to trigger those venoatrial baroreceptors. When those atria get full, those receptors are going to send sympathetic tone, say, hey, we're full, it's time to beat. And that increases the heart rate. When the animal exhales, everything reverses. Exhaling is passive, so sympathetic tone doesn't have to be so high. The pressure within the chest increases compared to what it was before. And when it increases, it slows down the filling of the heart, it slows down or reduces the preload. So now the stimulation of the atrial baroreceptors is taken away and the heart rate decreases. Now, this is a good example of something that can be overridden by pretty much anything. You don't see this on an excited dog. You see it on a relaxed dog. The sympathetic tone is low, and now these little tiny shifts in sympathetic and parasympathetic tone make the heart rate go faster, slower, faster, slower. So it's only going to happen in those situations. You see it under anesthesia a lot too. It's pretty normal. We haven't traditionally associated this with cats. However, with Holter monitor information from cats now, find that at home, relaxed, cats do this all the time. You'll occasionally see it under anesthesia. It's not usually as extreme, but it is normal in a cat too. So if you see a cat that's doing it, there might be something going on that's making them more prone to it. Maybe they've got high vagal tone, but it's not necessarily abnormal. There's something called the Cushing's reflex. If you've done any work with neurology patients, this is a reflex that you want to avoid at all costs. Cushing's reflex is specific to a order of events that happens when an animal's intracranial pressure gets too high. So there's a blood-brain barrier, right? The blood still needs to get into the brain or perfuse the brain. So in order for that to happen, the intracranial pressure, the pressure on the other side of the blood-brain barrier, the brain side, has to be lower than the blood pressure. If the intracranial pressure becomes higher than the blood pressure, the body panics because suddenly the brain isn't getting any oxygen. So the way that it panics is it triggers massive vasoconstriction to increase the blood pressure. The massive vasoconstriction does a good job of increasing the blood pressure, and you hopefully perfuse the brain a little bit, but that massive vasoconstriction, by causing high blood pressure, triggers the baroreceptors of the aorta, which drives the heart rate down. So what you'll see is intracranial pressure rises, this Cushing's reflex is triggered, blood pressure rises. And when I say rises, it generally goes in excess of 200. I've seen it as high as 300 when I've seen this happen. And then the heart rate will go down to about 30 as a result. So the brain is triggering the vasoconstriction for the blood pressure. The heart is saying, whoa, that blood pressure is too high, and it's kind of had a counter reaction. This is generally an indicator that this patient's about to die. The patients that have this are generally patients with head trauma or brain tumors or lesions, impaired clotting ability, which might cause a bleed in the brain, a hemorrhage in the brain, which will also increase blood pressure. So say you're in the hospital, you have a brain trauma dog come in. If you're monitoring it and the blood pressure goes up and the heart rate goes down rather dramatically, you need to get a doctor right now. This is a get the doctor off the phone or out of a room situation. It needs to be addressed. How you're going to address this is generally steroids and or mannitol, an osmotic diuretic to take all that pressure off the brain. But generally, once this happens, there's no coming back. Occasionally, if you treat it immediately, they're going to be all right. And when you see, if you've ever managed any head trauma dogs, and they start giving them mannitol and keep the head elevated, that's the whole idea. You're trying to keep the pressure in the brain from getting too high. The pressure in the brain gets too high, then the blood is not going to reach it. Brain's going to become hypoxemic, and then it's going to trigger this whole cycle, and then the body's going to shut down, and that's going to be it. Moving on to metabolic influences. These influences are generally more gradual. So your autonomic tone gives you kind of beat to beat regulation of heart rate. Metabolic influences, though, can override it to some extent. So things that increase heart rate, hyperthyroidism. If you ever have to anesthetize a hyperthyroid cat, what I generally see if it's not regulated, if it's an unregulated hyperthyroid cat, their heart rate's going to stay around 200 when you knock them out. It takes about half an hour for the heart rate to come down. They don't care that they're anesthetized. They've got so much thyroxine in their body, it's stimulating a high heart rate. Angiotensin, we'll talk about that in a moment. Catecholamines like dopamine, epinephrine, norepinephrine. So if you have something like a pheochromocytoma, which is a functional tumor of the adrenal gland, and it's putting these things out at an abnormal rate, it's going to cause high blood pressures. If you ever high blood pressures and high heart rates. If you ever have to be on an adrenalectomy surgery, the worst thing that can happen is that adrenal tumor is a pheochromocytoma. So it's active at producing these things. The doctor goes in to manipulate it, and there's a big dump of all these drugs into the bloodstream. Blood pressure and heart rate go through the roof. Your hyperaldosteronism patients can have a slightly higher heart rate. And hyperthermia also causes an increase in the heart rate. All other things being equal, temperature goes up, heart rate goes up, temperature goes down, heart rate goes down. Things that can decrease the heart rate if your animal's hyperkalemic, so your block cat's coming in with a high potassium, the heart rate tends to be low. Hypothyroidism can tend to push the heart rate down, but you have a big hypothyroid dog, if it's excited, it's still going to have a high heart rate. It's just something that might affect anesthesia. They might be prone to bradycardia and hypothermia, as I mentioned before. The renin-angiotensin-aldosterone system, which I always have trouble saying, something that we all learned in tech school or at some point, or it's been mentioned to us, but none of us understands it. I don't understand it at all, honestly. But it's a response to decreased renal perfusion. It starts this whole cascade of events. And one of the side effects is it tends to increase blood pressure and increase heart rate. So that makes sense, right? If the kidneys aren't perfused, the kidneys are going to start this cycle that's going to help improve cardiac output and is going to improve the perfusion of the kidneys. Now, this takes like 24 hours to take effect. It's a slow-acting mechanism. It increases sympathetic stimulation. Where you're going to see this is, say you're doing foreign body surgery on an animal that's been super dehydrated for days. This system is going to have been amped up. It's going to have started. So you can get them rehydrated. When you get them rehydrated, it's going to improve their preload. It's going to bring their heart rate down a little bit. They often come in with a really high heart rate, but you'll notice their heart rate's still going to be on the high side even when they come out of surgery. Even when you got the pain under control, it's still on the high side for a resting dog or cat. And that's because this system has taken over or has been activated. This system has been activated to try to keep the kidneys perfused while the animal is super dehydrated or hypovolemic. And it's going to take a little while for that to go away. So if you have a dog come in with a heart rate of 200, super dehydrated, has a foreign body, you do surgery, you give it a bunch of fluids, heart rate comes down to 150 or so, and maybe it stays that way for another 12 or 24 hours until all these sort of emergency systems have been down regulated, and then they'll get to a normal heart rate for their situation. All right, now let's get to the drugs. So we've talked about basically everything that's going on in the animal's body that regulates heart rate, and it's a lot of things, and a lot of them are pushing and pulling against each other. It's a matter of which one is stronger at any given point. The important thing to remember about the cardiovascular effects of any drug is it's highly variable. It depends on dose, depends on how you give it, what route, depends on the underlying rhythm of the dog and the cardiac status of the dog or cat or anything, any animal. And it depends on the interplay of all the cardiovascular reflexes that are already going on. So you can say a drug does this to the heart rate, but it depends on how much and how you give it and what's going on with the dog. I keep going back to dogs, but this applies to all mammals and to some extent your birds and reptiles. So opioids have a negative chronotropic effect. Chronotropy, if I haven't said it already, is just a fancy way of saying heart rate. You give an opioid, it's going to tend to lower the heart rate. How much it lowers the heart rate is going to depend on how you give the opioid and which opioid. We all know buprenorphine doesn't make the heart rate go down really fast. But if you give hydromorphone IV, heart rate's going to drop. Especially if you give it to a painful animal, their heart rate's probably pretty high. So the opioid creates a lower heart rate and you've taken away the sympathetic stimulation of the pain. That heart rate's just going to drop dramatically. So if you're giving a large dose of an opioid to an animal that's got heart disease, you might want to give it slowly so you don't bottom out their heart rate. If you're giving an opioid to an animal under anesthesia, you might want to expect their heart rate to go down. Whether that's a problem or not, if the heart's healthy, it's going to be fine. Ketamine. Ketamine is something that we've gotten lots of warnings about historically about don't give it to an animal with heart disease. It creates increase in heart rate. It can create some increased afterload. It does have a positive chronotropic effect, but it's fairly weak, and it depends on dose again. So if you're giving a zoo medicine, darting a tiger down dose of ketamine, it will probably increase the heart rate a little bit. But the doses that we normally use it at, the heart rate increase is going to be mild. And if you give it to an animal that's painful, relieving the pain has a greater effect than the positive chronotropic effects. One of the ways I know that ketamine was the right choice, if I give a little ketamine during a surgery, because I think the animal's having breakthrough pain, if the heart rate goes down, when everyone knows ketamine's supposed to make the heart rate go up, that means the animal had some breakthrough pain and the ketamine relieved it. Now the heart rate went down. And this is going to have a lot to do with how you give it as well. If you give IM ketamine to an animal, maybe with Dexmed, it's going to balance out. Their heart rate's not going to get higher. If you have an animal that's completely pain-free and relaxed, you give it ketamine, the heart rate will probably go up a little bit if you give it IV. So our alpha-2 agonists, famous for lowering the heart rate, right? Most of us are using dexmedetomidine. Apparently people are using recreational xylazine now, which seems weird to me. Doesn't seem like fun. You still use a lot of medetomidine, especially in horse medicine. So it does have negative chronotropic effects for two reasons. It has negative chronotropic effects, kind of like opioids do, in that it causes sedation. And that by itself is going to lower the heart rate because you're decreasing sympathetic tone. but it also causes a baroreceptor response or reflex vagal tone. Because it causes such strong vasoconstriction, that vasoconstriction causes hypertension, which causes a reflex bradycardia because the hypertension triggers the baroreceptors of the aorta, which says, oh, the blood pressure is too high now. Let's slow down the heart rate. And even once that vasoconstriction wears off, you'll still have a low heart rate because you've gotten rid of all the sympathetic tone by sedating the animal. So you trigger low heart rate. Once the vasoconstriction is gone, now the blood pressure is getting low. You don't have any sympathetic tone to bring the blood pressure back up. How many of you are using or have seen Xenalpha? Here's the question. Looks like the majority of people have at least heard of it, which is means that their marketing is going well. Some people weren't impressed. Looks like the majority of people have heard of it but not used it. It's commonly what I see. We have it on our ER and ICU here. We don't tend to use it up at anesthesia. So what's Xenalpha? Xenalpha is a newer drug. I think it's a couple years old now. It is a combination of medetomidine, which is an alpha-2 agonist, and vadenoxan, which is an alpha-2 antagonist. So vadenoxan is works essentially the same as atipamezole or antecedent. It's a alpha-2 reversal. The difference between vadenoxan and your atipamezole is that vadenoxan does not penetrate the blood-brain barrier, whereas atipamezole does. So because it doesn't penetrate the blood-brain barrier, it doesn't get rid of the sedation of the medetomidine. When you give atipamezole, you completely reverse your dexmed or your medetomidine. They wake up, the sedation goes away, the vasoconstriction goes away. But with vadenoxan, because it doesn't penetrate the blood-brain barrier, sedation stays, but the vasoconstriction goes away. In this case, because the two drugs are combined, the vasoconstriction just never really happens. It is not safe for cats. It hasn't been labeled for cats. My understanding is it causes some pretty profound vasodilation and hypotension in cats. There's a 2023 study, I believe this was funded by the makers of Xenalpha, comparing giving medetomidine or Xenalpha to dogs under the same situations. With medetomidine, the heart rate was lower, 43 on average. With medetomidine and vadenoxan, it was 66 on average. The heart rate was a little higher. They used some other metrics that showed that the cardiac output was a little bit better with Xenalpha. So do we need to just start using Xenalpha for everything? It's important to notice that in that study, there was no difference in outcomes. We know that our patients tolerate dexmedetomidine really well. The fact that Xenalpha maintains more blood pressure, more cardiac output, maybe it's good, maybe it's bad. Xenalpha tends to wear off quicker. So if you're doing, say, some OFA rads or something, maybe it's great. Give a box dose of Xenalpha, they relax, their heart rate doesn't go down too high, and they kind of pop back up without reversal. Although you can give atipamezole to an animal on Xenalpha to fully reverse it. But because we know it doesn't change outcomes, whether it's a real improvement or not on a healthy dog is kind of up to you. It's up to how you're using it. It may be better for a dog with heart disease or an old dog with age-related changes to the heart. Maybe those dogs that are old and we're afraid to use dexmedetomidine on, they'll do better because the heart rate doesn't go down, the blood pressure doesn't change as much. But that hasn't been studied specifically, and the drug is not labeled for animals with heart disease. So if you decide to try it that way, or practice decides to try to use it that way, it'll be off-label, and maybe you'll have good results, but you want to monitor them closely like everything else. Our induction agents have kind of a mixed effect on heart rate. They don't particularly decrease it directly, but you often see an increase in heart rate when you give alfaxalone or propofol, particularly in high doses, secondary to the blood pressure dropping, because propofol and alfaxalone decrease cardiac output. They can cause a little bit of vasodilation. decrease contractility. Alfaxilin has been shown to preserve a little more cardiac output than propofol, but they both decrease it. So you decrease all that, your animal's just going down, they're hypotensive now. If you see an increase in heart rate, it's usually a response of the arterial baroreceptors detecting that decrease in blood pressure and compensating for it with an increase in heart rate. And if you're lucky, it all balances out. You've made them hypotensive with the propofol, but the baroreceptors compensate, the heart rate goes up, and the blood pressure stays okay. But it's not a direct effect of the alfaxilin or propofol. If you're lucky enough to have etomidate in your hospital, we use that for really sick heart patients. Etomidate is an induction agent that has little or no effect on cardiac output or heart rate. Now, anesthetic gas, this goes back to what I mentioned when we started this lecture. Turn up the gas when the animal's heart rate goes up, turn down the gas when it goes down. You need to realize anesthetic gas can indirectly increase heart rate through vasodilation, triggering the aortic baroreceptors to try to improve the blood pressure by increasing heart rate. But anesthetic gas does not directly affect heart rate. Anything that comes from the anesthetic gas regarding heart rate or cardiac output is sort of secondary. Anesthetic gas's big contribution to complications is vasodilation, right? So if the animal vasodilates and it still has the ability to increase its heart rate to improve its blood pressure, it will. But that doesn't mean, well, that's a trap. So if your animal's depth is good and they're vasodilating from your gas and their heart rate goes up to try to compensate, and then you turn the gas up because their heart rate went up, that's counterproductive. That's not helping anyone. If you're anesthetizing a bulldog and its heart rate is really low, you say, oh, I'm going to turn the gas down, its heart rate is really low. That gas does not directly affect the heart rate. It just affects depth and vasodilation. The bulldog's heart rate is low because it has high vagal tone. So you're going to keep tweaking that gas down, tweaking the gas down, hoping for the heart rate to come up. And it'll eventually come up because the bulldog is going to wake up in the middle of the surgery. That's when you'll get the heart rate you're looking for. So when it comes to adjusting gas, I don't decide based on the heart rate. I will decide based on a combination of things going on. So if the heart rate goes up, I will check the depth. Let's check the palpebral response and the jaw tone. If that's all indicating the animal's getting light, then maybe increasing the gas is appropriate. Maybe the heart rate's getting higher because the animal's getting light. But if those are all normal, if the depth appears appropriate and the heart rate's going up, I'm going to look in other directions. Increasing the anesthetic gas is not going to get me what I'm looking for. Commonly, it's going to be either blood pressure's dropping, so you need to help the blood pressure, or you're having some breakthrough pain. If you're having breakthrough pain, you could increase the gas. It's probably going to drop the blood pressure. It's not going to give you any analgesia. So if you're having breakthrough pain, a better way to go would be maybe to redose a little bit of the opioids you use, maybe give a little bit of ketamine. Half mg per kg ketamine in the middle of any procedure will give you about 20 minutes of increased pain control. And that way you don't adjust the gas, you keep the depth right where you want it. Our benzodiazepines, pretty minimal chronotropic effect. That's why we use benzos on heart patients a lot. It sedates them without changing cardiac output. Acepromazine is another drug that has kind of mixed effects. It doesn't have a direct effect on heart rate, but it causes vasodilation, it causes sedation. The sedation may decrease the heart rate, but vasodilation may decrease the blood pressure, which may trigger the baroreceptors, which may increase heart rate. So acepromazine is a complex one as far as how it affects the heart. Anticholinergics. Now, we've kind of alluded to anticholinergics so far. Your anticholinergics are the drugs you give to make the heart rate faster, right? But it's good to know that anticholinergics don't actually directly affect the heart rate. They don't work on the heart specifically. Anticholinergics specifically block acetylcholine at parasympathetic receptors. So anticholinergics take away parasympathetic tone, and all you're left with is sympathetic tone. They do nothing to the heart directly. They just lower all the parasympathetic tone, which lets the sympathetic tone take over. The heart rate gets higher. That's why if you do the recovery program, CPR program, atropine is no longer considered a primary CPR drug because it doesn't restart a heart. It can still be useful because if you give the atropine, you're essentially taking the brakes off of the heart by taking away the parasympathetic tone. So if you get it going again, there'll be no parasympathetic tone to slow it down. But it's not going to specifically restart the heart. So your anticholinergics take the brakes off, which means they're very useful in your brachycephalic dogs, your high vagal tone animals, if they have low heart rate and their heart is not healthy enough to maintain their blood pressure at that heart rate, give them an anticholinergic and the heart rate will go up. It also works with puppies and kittens. Their blood pressure is highly heart rate dependent. So whereas we used to give atropine or glyco to everything we knock down, we do it more selectively now. If you do a lot of space and neuters and you give atropine or glyco for the space and neuters, probably appropriate because you want to keep their heart rates up. If you're doing a bulldog and you know it's going to be a long procedure and they're going to have a low heart rate, I would generally knock them down first and see how they're doing. If they're doing great, that means their heart's in good shape and they don't need it. But if they're bradycardic and hypotensive, it might be time for an anticholinergic. All of your adrenergic agonists have some degree of positive chronotropic effect, but it can be kind of mixed. Your dopamine and dobutamine will have a weak positive effect and it'll get higher at higher doses. Your epinephrine specifically will increase the heart rate. Norepinephrine has a weak positive chronotropic effect, but norepinephrine causes vasoconstriction, which increases blood pressure, which tends to actually result in a lower heart rate. But all these things are adrenergic agonists, and adrenergic receptors are your sympathetic receptors. So it's going to want to push the heart rate up unless something else counterbalances it, like vasoconstriction. It's good to know that most of the heart medications your animals come in on have negative chronotropic and some negative inotropic effects, depending on the drug. All your beta blockers, your atenolol, propranolol, sotalol, esmol, they're going to tend to push the heart rate down a little bit. Your calcium channel blockers like amlodipine and diltiazem also push the heart rate down a little bit. That doesn't mean you necessarily want to take them off before anesthesia, but it does mean you might have to help their heart rate a little bit if it gets too low during anesthesia. And bronchodilators. If you've used terbutaline as opposed to albuterol inhaler, if you use terbutaline, say on a fractious asthmatic cat, you can redose the terbutaline. It's going to cause bronchodilation, but also it's going to trigger increased heart rate. So one of the metrics we use to decide whether it's okay to give another dose of terbutaline is we check the heart rate. If the heart rate's really high, you probably don't want to redose the terbutaline. Albuterol is nice because it stays pretty localized when they use an animal albuterol inhaler. They don't tend to get such an increased heart rate because it all works within the lungs. One more drug today. IV contrast, specifically Omnipaque, not so much the contrast they use in MRIs, but IV contrast is a very thick drug. The reason I know that this has a negative chronotropic effect, not directly, but indirectly, is because when I first started doing anesthesia for CTs, we kept having these animals get really bradycardic during the CT and people would panic and they turn down the gas. And then the animal would wake up in the middle of the CT and everyone would panic. Sometimes they'd bite the tube, bite off their endotracheal tube. So what happens that I didn't recognize right away when I was a younger tech and was not appropriately supervised all the time, when you push the contrast, this super thick, high volume contrast that goes through the venous apparatus and into the heart and then comes out and hits the aortic baroreceptors, it's just like this big flood of Cairo syrup just coming through, and it stretches all those receptors, and that triggers bradycardia. Has nothing to do with the animal's depth. It's just that you're putting this thick, high volume fluid through, and it's triggering the baroreceptors. So if you are at a place that has a CT, you push the contrast and the heart rate goes down. I'm not saying you don't necessarily do anything, but I am saying you probably want to check the depth before you turn down the gas or whatever it is you're inclined to do. If their depth is fine, then it was just the contrast, and it usually wears off in a couple minutes. You give it a couple minutes, the heart rate comes back to where it was. And finally, the big picture I want you to take away from this is before you do anesthesia, identify risk factors for heart rate disturbances. Basically, this animal has like lower airway disease, if it's brachycephalic, has a reason for high vagal tone, untreated hyperthyroid cat, all these things that are going to cause heart rate disturbances. Recognize it beforehand so it doesn't catch you off guard. When a heart rate change or disturbance happens during anesthesia, don't just adjust the gas or adjust the depth. Try to identify the cause. So check the depth. If the depth is right where you want it, the depth is not the issue. You want to treat something else. And then consider their overall condition before you treat. So if the heart rate's a little high, but their depth is good, they don't appear to be painful, let it go. Maybe it's got some metabolic thing that you're not aware of. If the heart rate gets low, but they've got a healthy heart, their depth is great, they're not overly anesthetized, pain is under control, their perfusion, their blood pressure is great, just keep an eye on it. You don't necessarily need to change. If you start just treating the heart rate on an animal that's otherwise stable, you may cause complications that are unnecessary. These are some of the resources I've used if you want to look further into the subject. And that is it. Any questions? Question in the room. Mm-hmm. So the question is, I mentioned that Cushing's reflex is commonly associated with death. And so you're asking if the bradycardia, the bradycardic reflex is specifically associated with the death or is the trigger? So I think basically the question is, if the heart rate gets low, are they necessarily having a Cushing's reflex and they're about to die? So if the heart rate gets low, it can be for a lot of reasons. If you have a low heart rate and a blood pressure of 300 and some history that leads you to believe that there's something going on in the head, that is almost definitely a Cushing's reflex. You can sometimes suspect it's about to happen because things change a little bit and you're not sure. But if it happens, you're going to see an through the roof blood pressure and a super low heart rate. And if you see those two combined, particularly if you know that there's some head trauma or brain lesion or something like that, that is definitely a Cushing's reflex. And that animal is about to die in front of you, unless you intervene, and possibly even if you do intervene. Does that help or does that clarify? All right, any questions? Remote? I don't see anything. Okay.
Okay.
Anyone else in the room?
Just a thank you.
All right. Thank you, everybody.
Thank you so much, Travis. Take your mic back. Thank you. Okay, fantastic. So we're going to take a quick break and we will get started again at 11:30.
Thank you, everybody.